Hello, my name is Corian, and I'm joined by my group members Kathleen, Julia, Kevin, and Brianna. We have been asked with presenting in detail the arguments in favor and against the use of restraints and seclusions among persons with disabilities. To start, I want to define the terms we'll be using, provide a brief history of the use of the restraints and seclusions, and discuss the current laws and programs in place throughout the U.S. Restraints refers to any restriction of an individual's mobility, including the use of restraining devices, medical medical incapacitations, and physical restraint. There are currently no federal laws regulating the use of restraints and seclusions, but many states and organizations have adopted status defining when restraints and seclusions can be used. For example, the American Academy of Child and Adolescent Psychiatry, or AACAP, published its practices, uh, impairments, and determined that the use of seclusion and restraints was allowed in certain situations, such as prevent an individual from exhibiting dangerous behaviors to themselves or others. Other terms used for the physical restraint include the ambulatory restraint, manual uh, physical interventions, and therapeutic therapeutic holding. Seclusion refers to isolation of individuals in private spaces away from others as a punishment for interaction in extent that prolonged periods time or spent alone without the free ability and to have the space. Persons with disabilities refers to any individuals with a diagnosed diagnostic and sympathetic development, physical or mental disability that requires transitions and interventions to aid and improve equal life. In 2010, the National Disability Rights Network, or NDRN, issued a report that it's investigated the laws, policies, and guidelines of the United States and the territories. Their report included that, for one, 39% of the states still have no laws, policies, or guidelines concerning the use of restraint or seclusions. For two, 87.5% of the states and territories still allow prone and restraints that hinder breathing. And finally, 45% of the states and territories require or recommend that schools automatically notify parents or guardians of restraint or seclusion use. So clearly, there is an obvious disagreement on whether parents and whether restraints and seclusions should be used with people who have disabilities. Now that I have introduced the topic, my group members will now present the pros and cons sides of the argument. Let's start with the affirmative side. Kevin will introduce the main points, and then Brianna will provide the additional information.
Hello, my name is Kevin. I have worked in a special education school for 5 years as a paraprofessional and now as a behavior team member. I have witnessed and participated in the use of restraint with persons diagnosed with developmental disabilities firsthand.
And my name is Brianna. I have worked in the field of applied behavioral analysis for 1 year as a behavioral therapist. I have both witnessed and participated in the use of restraints with individuals with autism.
So everyone is always concerned with the potential for harm that a restraint can possibly cause when improperly applied. But even more concerning than that are the risks of not using a physical restraint to de-escalate a violent situation. Let me be clear, physical restraint is a last resort. Following the ethical code that is applied to being a behaviorist, using the least intrusive method is a priority and will remain that way as stated by the Ethical Code 4.09. And that states, behavior analysts review and appraise the restrictiveness of procedures and always recommend the least restrictive procedures likely to be effective. But safety is also a priority, and so is the well-being of the client. Certain situations arise that cross the threshold from manageable to dangerous. That is where physical restraint and seclusion are to be used, to keep everyone safe, the client, staff, and bystanders. When verbal de-escalation techniques are no longer effective or viable, and the at-risk individual becomes irrational, there is no predictability to their actions or behavior. This is where the core ethical principles of doing no harm, benefiting others, being just, and accepting accountability as a behaviorist come into play. Working with this population of individuals can oftentimes, for a variety of reasons, escalate to a point of violence. Every staff and client has the right to safety in the same environment and environment safe. Without restraint, what would a staff member do? Continue to let the student or client aggress towards them and other students, staff, or even themselves to the point of injury? Restraint immediately reduces the severity of inflicted harm when safely and properly applied. The opposing side of this debate may tell you it is an evil that should be removed and have legislation passed against it, citing instances of injury. But take a moment to think about how many more injuries there would be if restraint had not been used as a last resort to cease a violent outburst. These injuries occur when restraints are obviously improperly applied or attention is diverted away from the secluded student, both very important aspects of using both, of which the large majority of staff members are conscious of. This is where nonviolent training methods come into play. Many programs exist to serve our community. Some of these are CPI, NAPI, Handle with Care, and PROACT. Not only do these programs train effective and nonviolent restraints that do not harm the individual being restrained, but they also teach verbal de-escalation and personal safety techniques to use prior to the use of any physical restraint. Many respectable schools and programs have their own requirements of their staff. For example, a school might say, trainings must be done annually and staff must be passed from a qualified instructor in order to be eligible to use the restraints or even remain an employee there. For example, Crisis Prevention Institute, CPI, teaches the following. It starts off by instructing how to identify a crisis. If you'll look at slide 1 of the PowerPoint, it shows a glimpse of the CPI crisis development model, which they use to explain the stages and identification of a crisis. Identifying and responding appropriately to the different types of communication is next. This includes nonverbal communication. So they basically tell you how to demonstrate ways to adjust your own nonverbal communication body language to prevent and de-escalate a crisis situation, how you're displaying yourself, how's the client seeing you. Then it teaches you paraverbal and verbal communication. It demonstrates the distinctions between vocal speech and how each can be perceived differently. How can you convey your message appropriately to prevent and de-escalate a situation? Next, it moves on to verbal intervention. It demonstrates how to use verbal directives appropriately to prevent and de-escalate the situation when defensive behavior is being displayed. Then it moves on to disengagement skills. So this is actually when the incident turns physical and the at-risk individual is aggressing towards staff. These are safety techniques to keep oneself safe without having to use restraint. This is paired with the verbal de-escalation techniques taught in the same course. Finally, we move to the physical intervention skills. This is where the learners are taught how to safely and effectively use restraint to de-escalate an acting out person. CPI stresses that the conditions needed to be present for this involve, the risk of not doing something must be greater than the risk of restraining. It teaches quick risk assessment skills to the learner, allowing them to make quality and effective decisions during crisis. It also teaches appropriate nonviolent techniques for varying situations involving multiple team members and explains their roles accordingly. If you look at slide 2, it shows an image of a safe and effective seated hold taught by CPI. They also instruct how to build a therapeutic rapport following physical intervention. This is a very important that many overlook. I cannot reiterate this enough. This all boils down to safety of everyone involved. With cases of severe self-injurious behavior and aggression towards staff and students, what other choice do you have?
Would you want to work in an environment where you are expected to be assaulted daily while implementing a new intervention, or even sit there and watch a client strike themselves repeatedly to the point of needing serious medical attention? Your answer is no, of course not. Restraint makes it possible to work in such environments where those situations arise. If you go to slide 3 of the supplemental material, you will watch a short video of a child with SIBs. This is just an example of what children with severe self-injurious behaviors are like throughout their day. You can see in the video that their mother and presumed brother are struggling to put his sneakers on and are attempting to hold his wrist while doing so. With a safer and proper restraint, such as the one on slide 4, which is the CPI interim hold, it would be safer and more effective to complete daily tasks like this and keep everyone safe. It is not part of the job to tolerate behavior which threatens our safety and well-being. We all have the right to work in a safe environment, free from physical assault and a means of protecting everyone in escalated situations. In Los Angeles, concerns over violent student behavior has been brought to light by many special education teachers. These teachers state the following about current legislation protecting their rights and also the injuries one of them has been forced to deal with as a direct result of student behaviors. Teachers and education support professionals, also known as ESPs, also have rights. Schools are workplaces regulated by the Occupational Safety and Health Act. Under that legislation, says Neimer, school board members, administrators, and others must take every reasonable precaution to protect all workers, including teachers and ESPs in a school setting. But educators say that isn't happening. I am kicked, hit, pinched, and spit on, says Faith Bradsetter, a special education teacher and member of the Los Angeles County Education Association. I have had my nose broken 3 times, torn my rotator cuff in both shoulders, injured my back, shoulder, and elbow, and had a ligament torn in my thumb. Now I have a piece of bone floating around in my hand. I have also had my ankle reconstructed. Most of our students have behavioral issues, says Bradsetter, vice chair of the SEC. Some strike out intentionally when they are angry. Some may not be aware of the pain they are inflicting. Our administrators listen, but not much has been done, she says. In cases of severe violence or SIBs without restraint, staff members would need to call crisis and have the police medical personnel bring the client to an under-equipped hospital, which would further traumatize the student. A restraint or de-escalation combination could potentially keep the student in the familiar environment of their school, and once they are safe, continue on with their day, and thus their education and continuing pursuit of independence. If every time a student got escalated to the point of a severe violent or SIB, the student may learn that as an escape behavior for getting out of any demand. Overall, physical restraint is not to be used as an intervention itself, but rather a component of a much more comprehensive and therapeutic approach. It enables staff to implement a new intervention without fear for the possible reaction to the new interruption in the client's daily life. It is a way to keep everyone safe, including the individual, and keep everyone free of harm. When practiced safely, it can also prevent injuries from occurring.
Thank you, Kevin and Brianna, for presenting your arguments on the affirmative side of the debate. Let's now move on to the negative side of the issue. Julia will present evidence against the use of restraints and seclusions, and Kathleen will provide additional information.
Hi, my name is Julia. I have worked in the field of applied behavioral analysis for the past 3 years as a behavior technician, a special education teacher, and now a case manager within ABA clinics. I've witnessed and participated in the use of restraints and seclusions with persons diagnosed with developmental Kathleen, I think you're on mute.
Okay. My name is Kathleen. I work in the field of applied behavior analysis for a year as a program director in a treatment center. Before that, I was a special education teacher. I've witnessed and participated in the use of restraint and seclusion with persons diagnosed with developmental disabilities firsthand.
So one major concern with the use of restraints with persons diagnosed with autism or other developmental disabilities are the physical risks or harms that can be caused with the use of restraint. Some physical side effects that have been previously reported in direct correlation with physical restraint include asphyxiation, which is also known as suffocation, a condition arising with the body being deprived of oxygen, which causes unconsciousness or death. Aspiration, which is breathing in foreign objects, including saliva, into the airways. Blunt trauma to the chest, which includes any physical injury to the chest wall, the ribs, hearts, lungs. This can be in the form of bruising, tearing muscles, broken bones, broken ribs, anything like that. Thrombosis. This is trauma to the veins or arteries. It causes local coagulation or clotting of the blood and obstructing the flow of blood to the circulatory system. Bruises, cuts, wounds have all been reported and very common with the use of restraint. And lastly, mortality, which is death, can be caused by the use of restraint, physical restraint. Let's look a little deeper into these physical side effects. So asphyxiation. The Joint Commission on Accreditation of Healthcare Organizations Board of Commissioners reviewed 20 cases of deaths in patients of physical restraint. 1/3 of those patients were children, 1/3 adults, 1/3 geriatric. Of all of those children, they died in therapeutic holds, or so they think, therapeutic holds. 40% of those deaths were attributed to asphyxiation, related to putting excess weight on the back of the prone patient or putting a towel or sheet to cover the patient's head to protect against spitting or biting. This obstructed the airway, and they've also obstructed the airway when putting a patient's arm across the neck area. Asphyxiation can also be caused by objects being used during the restraint. As I stated above, oftentimes towels or clothes may be used on the client's face to block spitting. If you look at slide 5 of the supplemental material PowerPoint, there is a picture of a restraint and the person's using a towel to cover the client's face. Asphyxiation can be also a big risk when you use a prone restraint. This can predispose you to suffocation. So a prone restraint is a floor restraint in which a patient is lying face down on the floor without any movements or arms or legs. So with aspiration, the supine restraint can predispose aspiration. So supine restraint is floor restraint in which the patient is lying face up on the floor with the movement of arms and legs restricted. Bruisings, cuts, and wounds. If you look on slide 8 of the supplemental material, there's a great example of how dramatic bruising, cuts, and wounds can be after the use of restraint. And lastly, mortality. A study by Nuno et al. Found that 45 fatalities between 1993 and 2003 in child and adolescent psychiatric facilities were all related to physical restraints. So in addition to physical, let's now look at potential emotional side effects used by or caused by the use of restraint and seclusion. These can include increased anxiety, which is the feeling of nervousness or unease, typically about some imminent event or something with an uncertain outcome. Next is depression, which is the feeling of sadness, and abandonment, which is the feeling of being rejected, insecure, and discarded. With increased anxiety, often patients are unaware of the reasons or participating events in the use of seclusion or restraint. This causes them feelings of anxiety, unsure when the onset of restraint or seclusion may occur. Some of the patients have described this trauma as similar feelings to being physically abused or even raped. It's traumatizing to both the individuals performing the restraint and, as I said above, traumatizing to those being restrained. So it can be traumatizing for all parties involved. Depression in relationship to the coercive nature of restraint. A patient may feel hopeless or have despair because their personal opinions or decision-making processes are being taken away from them, which can cause depression. Lastly, abandonment. So this happens most times within seclusion. Oftentimes staff may check on a patient, but the patients are unaware. And this may cause feelings of being abandoned, not cared for, discarded, as I stated above. So in addition to physical and emotional, we're going to talk about cognitive effects. So cognitive effects can be caused by restraint and seclusion. It can cause some cognitive changes within the patients. Previously, patients have experienced some cognitive changes such as sensory deprivation during the use of seclusion rooms. Kennedy, Williams, and Pursuit, 1994, found that 20 of the 52 patients who were secluded began to hallucinate and hallucinated during the experience due to the absence of sensory stimulation.
Along with physical, cognitive, and emotional effects, there are multiple legal issues involving restraint and seclusion. These include inadequate laws and numerous lawsuit findings. At this time, despite the knowledge that restraint and seclusion are ineffective and dangerous practices, there are no federal laws or guidelines governing the use of restraint and seclusion in schools. Schools are governed by state laws, guidelines, or suggested practices. In some states, there are no laws or guidelines. This leaves little protection for students and families of students who have been subjected to restraint and/or seclusion. Let's take a closer look at the statutes, regulations, and guidelines regarding restraints and seclusion for the states represented by group members: California, Indiana, Michigan, Missouri, and New Jersey. Please reference slide 9 on the PowerPoint to see a more detailed depiction of the table. Statutes, regulations, and guideline statistics from the U.S. Department of Education for each state have been included in the table. Just a quick reference, in the state of California, I found it very interesting that Brianna was discussing something that one of the Los Angeles schools said. And if you look at the table, the very first state is California. Physical restraint in the state of California for 1 year was reported at 1,455 students that fall under IDEA, and 1,456 of those students were male. These findings, I will say, were noted in the report as not being conclusive, acknowledging that many of the schools in each of the states do not report all instances of restraint or seclusion. Many of these restraint and seclusion have been practices implemented in schools and other facilities for decades. At this time, numerous court cases have been heard regarding these practices. Many of the cases have been brought before the court by parents. Let's take a look at some of these cases, the issues, and the decisions. Details for each of these cases were found in a report generated by the Health, Education, Labor, and Pensions Committee by the United States Senate entitled "Dangerous Use of Seclusion and Restraints in School Remains Widespread and Difficult to Remedy, a review of 10 cases." PowerPoint slides 6 and 7 include video examples of what will be detailed below. One Connecticut public school placed disruptive students in seclusion or screaming room. Other students complained of sound from the room, and custodians reported removing urine and blood after it had been used. The outcome of the case resulted in no change in law. Connecticut schools still put no regulations on use of seclusion. At one Florida public school, a general education teacher restrained a 12-year-old boy with a developmental disability 89 times in 14 months. Of the 89 times, 27 of them were in a face-down position. The parents were not notified of these occurrences. The court dismissed the parent's suit because the school did not show indifference to the education of the child. A 13-year-old boy with depression and ADHD committed suicide by hanging himself after he was secluded for multiple hours. On 2 previous occasions, he made statements that he was going to harm himself. The parents sued the Georgia school, claiming school did not notify them of the student's suicidal threats. The court ruled that the school did not show deliberate indifference despite knowing about the threat. A North Carolina public school case included 18 special education elementary students. One 5-year-old student was strapped to a chair despite having shown no aggressive behaviors. The important thing to note here is that the mother did give permission for restraint, but only in the presence of aggressive behaviors. The Office of Civil Rights found numerous counts regarding IEP issues and lack of parental notification. The school district agreed to train staff, but they no longer provide training. A Pennsylvania public school special education teacher was accused of multiple counts of abusive acts against 7 children with disabilities. Acts included strapping children to chairs with duct tape and bungee cords. The families were awarded a $5 million settlement. However, a district court dismissed the claims. The court's decision was based on the parents not exhausting the due process, and the school's actions did not prove negligent.
Both sides have presented their arguments on the affirmative or negative side, and the debate questioning the use of restraints and seclusions on persons with disabilities. Both sides have been examined Now, such sides of the argument will be presented by their closing remarks. The affirmative side will go first, and then the negative side.
So, the proper use of restraints and seclusion has many benefits for all involved. It immediately reduces the risk of inflicted harm to the client, staff, and bystanders. Restraint enables workers to feel safe in an environment where violent outbursts are unfortunately a very real possibility and in some instances very common. With many companies devoted to ensuring proper restraint methods that do no harm, it is a priceless and necessary last resort for staff to keep everyone safe.
The use of restraints and seclusion can lead to serious or even fatal consequences. Depression, anxiety, asphyxiation, aspiration, and even death can be caused by restraints and seclusion. As you heard, there are many cases that prove this point. It is dangerous, it is underregulated, and it has life-threatening consequences.
In this debate, we have discussed in great length the legality and ethics involved in the use of restraints and seclusion on persons with disabilities. Both sides have provided evidence in support of their claims for or against the use of restraints. On one hand, the affirmative side has argued that restraints and seclusions can be used in specific contexts with appropriate paraments in place. On the other hand, the negative side has argued that restraints and seclusions cause physical and psychological harm, and their use should be limited or eliminated altogether. Because there are no federal laws preventing or allowing the use of restraints and seclusions, this problem will remain an issue for families in all 50 states. It is recommended that federal laws be enacted, and that will echo the mimic in the recommendations of the BACB's Ethical Compliance Code, along with the laws and status of many states to allow restraints and seclusion to be used only as the last resort. When physical harm is imminent, when all other options have been tried, informed, and consent, and when need to be trained and competent professionals. And with that being said, this will be the end of our video.
Oh, well, actually, we are going to move on to answering the 2 questions presented to us by our professor. And I believe Kevin will be reading the questions, and we will be answering.
I apologize.
All right. So as a BCBA or therapist, you work in a facility that serves teenagers with severe challenging behavior and SIB. What do you do if the parents of one of those children tells you that they don't want you to use any restraints for their child? In following the code of ethics, talk through how you would handle this situation and if you would or would not continue services.
If a parent of a teenage client with severe challenging behaviors or SIB refused the use of restraint, I would first hear their concerns. As part of the Ethical Code 1.05, as outlined by the BACB, it's important to address those concerns in a language that is fully understandable to the recipient of service or caregiver, or recipient of the services or their caregivers. I would provide peace of mind that the child is in no harm during the use of restraint. I would explain that it is part of our ethical principles to do no harm. Safety is always our #1 priority. I would also explain that the restraints are not used to coerce or manipulate, only to ensure safety of all parties. Section 2.09 of the Code of Ethics discusses treatment and intervention efficacy. The clients have the right to an effective treatment. As a behavior analyst, it is our obligation to base effective treatment on the research literature and scientifically significant treatments. I would share the research and science behind the use of restraint and how that research is implemented within the client's treatment. Section 2.15 discusses interrupting or discontinuing services. Services should only be discontinued when the client no longer needs services, or the client is no longer benefiting from services, or the client is being harmed from services, or lastly, when the client requests discontinuation of services. In this case, if the client or the caregiver requests discontinuation of services, then the services can be terminated. However, refusal to consent to the use of restraint would not be means to discontinue services only after de-escalations or other procedures have been deemed ineffective. Finally, I would encourage and maintain an open forum for communication between myself and the parent. Section 9.03 of the Code of Ethics explains the importance of consent. If consent was not given, restraint cannot be used. Overall, I would share the literature and personal knowledge about the importance of restraint, but ultimately respect the wishes of the client if risk of serious harm is not evident.
That was a great response. All right, so on to the second question. Has anyone on this debate team ever been in a situation where you have learned or seen proper/improper use of restraints? Have you had experience with de-escalation procedures? Give specific examples, and if they did or did not follow specific ethical codes.
So I have been in both a situation where proper restraints were learned and used. To work at the center I do, everyone in the building has to be properly trained in the use of CPI, which is crisis prevention intervention holds, and they have to know when it's appropriate to use them. So while restraints are frequently used at my center, de-escalation procedures are typically the first go-to. I specifically can recall the day when a child was becoming aggressive towards me, and typically the protocol is to just put the child into child control restraint. But just like the protocol and Ethical Code 4.09, least restrictive procedures are to be used first. Knowing this, I had the child count back from 10 and do a few breathing. The breathing techniques had actually calmed the child down, which allowed for the original demand to be completed nicely, which then led to him receiving his reinforcer. To my knowledge, I believe that this situation followed all ethical codes. Least restrictive measures were taken, and no restrictive measures were used as a punishment procedure. Really does conclude our video.
Yes, and with that, our debate is concluded. Thank you, everyone.
Thank you.
Thanks, guys.